if you consider the mucogingival procedure, namely the treatment of gingivalization, I realized that in Italy there is a great request of this treatment, probably because we spent a lot of time on the solution of this problem. So there are many schools that were interested in this treatment. The School of Bologna with Massimo De Santis and Giovanni Zucchelli, my school, Roccuzzo School in Torino, and other colleagues. And probably because the interest in solving this problem is very high in the patient, especially in young people, because of this intensive reclamization of the toothbrushing, of the material, make that recession frequently occur in the frontal teeth. And today there is a great research on the aesthetics and cosmetic surgery. And the cosmetic surgery means also the treatment of gingivalization. And our study, I began in 1970, and our study probably stimulated the other colleagues to improve always over time this technique. Today, especially the Zucchelli solution are absolutely fantastic, it's incredible, it represents, I think, the top level standard in the treatment of recession type defects. We started with the treatment of gingivalization. In the file 1970, in my hand I have only 3 gingival grafts, just positioned at the basis of the recession defects. Sometimes the recession was arrested, sometimes due to a continuous creeping attachment, we have also an improvement of the exposure surface in terms of coronal displacement of the gingival margin. In the year 1999, yes, after the first paper described by Raul Caffisi and Allen and Miller, I start my experiences just in performing a coronally advanced flap. Sometimes we had good clinical results, sometimes we have kind of relapse of the gingival margin. Later on, in the 1990, the new approaches, namely connective tissue flap plus coronal advanced flap, was published in the United States by means of Langer, Nelson, and that was a very intelligent approaches, because the connective tissue graft mediates the healing response between the exposed surface and the coronal advanced flap. Therefore, I started also this procedure and obtaining better and stable clinical results than those if you compare with the coronal advanced flap ones. We did a lot of this procedure, and now, according to the new information related from the treatment of multiple recession by means of Zucchelli and De Santis, we started to treat also multiple recession. The original technique for the treatment of multiple recession that was very intelligent was that avoiding the vertical lesion incision, there is a better blood supply to the flap, and treating multiple recession gave the opportunity to have, as a result, a complete root coverage along with a recession reduction. Therefore, we start also with this technique. And if at the beginning it was impossible to treat contemporaneously many of recession, today is easier than those to treat a single one, because for the single one, 2 vertical incisions are needed instead of a long flap without vertical to treat multiple recessions. I used to collect this data, and the short-term result demonstrated that there was a good clinical result. But following calf procedure, I published a couple of articles showing that after 10-15 years, the 40% of the recession treated by means of coronal advanced flap receded during time. This is interesting information, especially for the patient, because sometimes patients come in our office asking for the prognosis of the treatment in terms of complete coverage, if the result is stable. And therefore now, after this information, I used to say to the patient that it's possible to treat a gingival recession with a predictable complete coverage. But it's possible that during the years a recede can occur. And I think this is an honest thing to spread with the patient, because this is the clinical reality. And another interesting indication comes from a large study. During last year, I did this procedure many times, thousands, but during last years, I began to have some doubts on the necessity of this treatment of gingival recession. In fact, the decision of treatment depends on the knowledge of the periodontist, is her skill, is her economic benefit. I performed this large epidemiological study on the recession perception by the patient and the necessity of treatment. And the results were very interesting, because it was performed on a large number of patients and large number of recessions. And it was interesting to note that only the 28% of recession were perceived by the patient. Out of the 28, only 73% were asymptomatic, and only 27% symptomatic associated with aesthetic compliance and dental hypersensitivity. And it was more interesting the result that showed that only 11% of the patients requested treatment, of only 7% of recession. That was very surprising. In addition, considering that the lapse of the recession during the time, and that the complete coverage is not predictable a priori, I think that today, the treatment of unperceived, asymptomatic, and non-requested recession should be considered very carefully. Today, in fact, I used to do very few procedures treating gingival recession. Magnification, today, I think a magnification is very helpful for this treatment, because I think we have a great perception of the tissue. Using microsurgical blades, microsurgical instrument, microsurgical suture, it's possible to avoid amazing stressing on the tissue. And I think that is useful, especially when we have to suture the connective tissue graft over the exposure surface. And in that situation, our suturing technique must be performed perfectly, just to maintain the graft absolutely firm on the exposed surface. Therefore, I think that it's not easy to use the microscope, but during this aesthetic procedure, they are very useful. Periodontics is absolutely useful for orthodontists. In fact, I studied since a long period of time the mucogingival properties in adults, and transferred what we learned with this experience in the young patients, especially those who are going to orthodontic treatment. We were able to describe several different surgical approaches to save and maintain the cutaneous tissue before and after orthodontic treatment. We call that mucogingival preventive treatment before the eruption of the tooth. Mucogingival interceptive treatment when the tooth was erupted but not completed, and reconstructive mucogingival surgery when it's needed to rebuild the lost keratinoid tissue. A typical, but the most typical question that arises from orthodontists is whether a gingival augmentation procedure, a free connective tissue graft, should be performed before orthodontic treatment, especially in patients with a thin periodontal morphotype. And I think I can answer considering two variables. The first one is that we have to consider the orthodontic tooth movement. In fact, the Swedish school, Teilhade, Wenström, and all these teachers showed us that if a tooth is moved orthodontically into the envelope flap of the alveolar bone, the risk of development of gingival is low, independently of the amount of keratinoid tissue that covers the alveolar process. The second consideration is based on the famous research that showed that periodontal health can be maintained without loss of attachment, without recession, in sites with or without attached gingiva if a good plaque control is established. Therefore, if a tooth is moved inside the cortical bone plates in a patient with good plaque control, the prophylactic use of free gingival graft is not necessary to avoid the development of recession in the patient with thin periodontium. On the other hand, if a tooth is moved outside of the cortical bone plates in the regimen of a poor plaque control, the amount of keratinoid tissue, the volume of the gingiva, is a risk indicator for development of gingival recession. Therefore, in these cases, a free gingival graft may be recommended before the orthodontic treatment. When treating an erupted tooth, in general canine, there are two main differences. If the canine is erupting in the palatal side or in buccal side, usually the palatal side is found in the female more than the male. Generally is bilateral. The buccal is instead more frequent in male. Before the eruption of the tooth, that can be impaired, the quality and the amount of keratinoid tissue. It's possible today to prevent or intercept this eruption, opening a flap and together with the orthodontist, and to put a bracket on the teeth and making it to come in the middle of the alveolar process, where normally the amount of keratinoid tissue is adequate in the buccal side. On the other hand, if the tooth is still erupted, the treatment depends on the position of the erupting tooth. If the tooth is erupted in the context of the keratinized tissue, a double pedicle flap may be performed because we can move, leaving the tissue attached mesially, moving the tissue coronally, apically to the emerging tooth, and in few days, the tooth erupting take with it the tissue, just maintaining and save the tissue that otherwise should be destroyed. If the tooth is erupting a little bit more apically, an apical position flap with two vertical incisions may be performed to position this tissue apically to the emerging tooth. If the tooth emerges very far in the middle of the mucosa, a free gingival graft may be performed using the entrapped gingiva between the erupting tooth and the corresponding decidual. And in this way, we remove completely the gingiva and we position it apically to the erupting tooth. In this way, we can maintain and save the keratinized tissue during and after orthodontic treatment. The procedures are very atraumatic and are able to maintain this precious tissue during the life of these individuals. Periodontal medicine is another interesting issue of medicine of the period, but it is still an open question that is not yet completely clarified. From epidemiological studies, in general retrospective, we know that periodontal inflammation can be considered an independent indicator of systemic diseases such as cardiovascular diseases, low weight birth infants, arthritis rheumatoid, diabetes. It is very well known that some factors of periodontal disease, infection, inflammation, adaptive immunity, has a strong impact on the inflammatory adaptive immune response. An interesting article was published by Tonetti and Aiuto on the New England Journal of Medicine, and they demonstrated that periodontal infection may impair the vascular endothelial function.